thank you everyone so much for joining today's learning community event on guiding low and very low carb diet interventions. Before we get started and turn it over to Dr. Grezda, we'll just walk through the brief information about claiming your CME for it. So you'll receive a handout if you haven't already with the directions sent to your email as well. So don't worry about capturing all these. We'll also send out the slides. To get CME credit, you'll text this number by tomorrow. That gets you signed up. Even if you miss that and happen to not send the text, you can still complete the evaluation online as well and get credit for that as long as you complete that by May 12th. Next slide. And the CME or continuing education credits that we offer medicine CME, nursing CE, pharmacy CE, and dietetics CPEU. And as far as like people who are speakers or on the planning committee that have relationships that need to be disclosed, Dr. Ashman, who helped to plan this, is disclosures that she has stocks in publicly traded companies or stock options, excluding diversified mutual funds in Abbott, AbbVie, Johnson & Johnson, Merck. And with that, I will hand it over to Dr. Grezda to present. She is a primary care physician and helps to lead the low carb diet portion of MCT2D and is our expert on that. She is a physician at the VA in Ann Arbor, and her areas of practice include primary care, obesity management, prevention of diabetes, and other obesity related conditions. And we're very lucky to have her here today to speak to us about low and low carb diet interventions with CGM. Thanks, Dr. Grezda.
Thank you, Jackie. Thank you all for being here. As Jackie said, I'll be discussing using continuous glucose monitoring and dietary carbohydrate restriction to support patients with type 2 diabetes. And actually, one thing I'll say is, how do we want to handle questions? I think we can save them till the end, although if there's something that I'm saying that needs clarification or you think would benefit from further discussion as we go, I am very happy to have you jump in and interrupt. Jackie, I don't know if you could potentially monitor the chat for any questions that should be addressed as we go.
Yep, absolutely. Happy to do so. Do you want me to jump in and interrupt you as they come in?
Yeah, I mean, I think if it's like, you know, tangential to the topic and we can wait till the end, fine. If it should be clarified, you know, as we go, that's great too. Perfect. So I want to start by introducing you to Mr. L. Mr. L is a 65-year-old man. He has a history of obesity and type 2 diabetes. His weight is 336 pounds. His BMI is 43, and his A1C appears well controlled at 7%. However, he is requiring multiple medications, including multiple daily doses of insulin, to achieve this level of glycemic control. He's also facing a number of other weight-related conditions. And he really is frustrated that he's taking so many medications to control his conditions, yet he's gaining weight and he feels like his health is worse than ever. So my goal for today's talk is to help you understand how we can better support Mr. L and our many patients like him. To do this, I'll start by discussing a weight-focused rather than a glucose-focused approach to type 2 diabetes management. We'll talk about carb restriction as a tool to support weight loss and glycemic control. We'll talk about continuous glucose monitoring as a tool to guide tailored nutrition counseling and address the fact that there is no one-size-fits-all dietary change approach that works for any patient or any patient with diabetes. And then we'll circle back to Mr. L and end with his story. So historically, type 2 diabetes has been considered to be a chronic and progressive condition. We accept and we expect that patients will require more and more medications over time to control their blood sugar. And really, blood sugar has been the focus of our treatment, but this is not the root cause of the condition. And at times, treatments, for example, insulin is the obvious example, can help control blood sugar levels while predictably causing weight gain in worsening the underlying pathophysiology of the condition. So there's now growing awareness of obesity, or more specifically, adiposopathy, which means sick fat and really refers to the presence of visceral fat, as the root cause of type 2 diabetes. And so strategies to help patients achieve a healthy body weight can minimize or avoid the need for specific glucose-lowering therapies. And I really want to emphasize that healthy weight from a metabolic perspective does not mean normal BMI. It's not BMI, but rather visceral fat or visceral adiposity that drives metabolic dysfunction. And this concept is shown in this image on the left. The first person has more visceral fat, this is the red area, and may be more likely to have type 2 diabetes as compared to the patient on the right who has a higher BMI, but lower visceral fat. So really, type 2 diabetes results largely from accumulation of fat in the liver, resulting in insulin resistance, as well as fat in the pancreas, which can result in an insulin, sort of a functional insulin deficiency, or where we're not making enough insulin to overcome the insulin resistance in the liver and peripheral tissues. And so regardless of a patient's BMI, weight loss to some degree can improve glycemic control and can improve glycemic control for patients with type 2 diabetes. And of course, weight loss can be achieved through a variety of strategies. Any patient-centered, evidence-informed approach can be used. This ranges from all sorts of lifestyle change interventions, anti-obesity medications, including new and old agents. Even our older oral agents have evidence of supporting improved glycemic control through weight management. And of course, bariatric surgery for patients who are interested in that approach. For today's talk, we're going to be talking about carbohydrate restriction as one tool to support weight loss and glycemic control. Of course, there's no one-size-fits-all approach to dietary change. I think this is kind of the mantra we've been hearing for several years now from a number of organizations, including the ADA. There's not an ideal percentage of calories from carb, protein, and fat for all people with diabetes. There are, however, dietary strategies that might work best for individual patients. And for patients with type 2 diabetes, some degree of carb restriction can be highly effective. The ADA is one of a number of organizations in the US and internationally that recognizes carb restriction or the potential for carb restriction to improve glycemic control for patients with diabetes. Their statement says reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia and may be applied to a variety of different eating patterns that meet individual needs and preferences. And I think this latter part of the statement is something we've really focused on in MCT2D, and a lot of the low carb resources that have been developed are tailored to different eating patterns. So this means that somebody can choose to follow a vegan or vegetarian eating pattern and restrict carbohydrate. Same thing with, named eating patterns like Mediterranean style, etc. And we have culturally tailored meal plans for carb restriction as well. Oh, I don't know why my slides are frozen. Okay. There is a physiologic rationale for carb restriction. Type 2 diabetes is often characterized by hyperinsulinemia. Insulin is an anabolic hormone. This is sort of a simple explanation, but I think conceptually is easy to explain to patients. Where insulin is an anabolic hormone, it promotes fat storage and inhibits weight loss. And dietary carbohydrate is the most potent stimulator of insulin secretion. So really reducing dietary carbohydrate intake leads to a reduction in circulating insulin levels. This allows for lipolysis. We sort of have a fuel switching, or the ratio of insulin to glucagon switches such that Fat can be broken down. We mobilize stored fat from peripheral tissues as well as from the liver and pancreas. The cumulative effect is a reduction in insulin resistance, or stated differently, improved insulin sensitivity, as well as improved secretion of insulin. And for patients, this translates into improved glycemic control with fewer or no medications. I don't know why my slides are not advancing, at least there. Okay. So one thing that we, I think, have also reiterated throughout our MCT2D lectures on carb restriction is that throughout the literature, there are sort of a variety of definitions for low or moderate carb or very low carb diets. In general, low carb diets are generally defined as having 50 to 130 grams of total carbohydrate per day. Very low carbohydrate diets are generally defined as having 20 to 50 grams of net carbohydrate per day. So what does this look like? Here's a comparison of a low carb plate with the ADA's standard plate method. You can see they're fairly similar. Perhaps the low carb plate has slightly fewer complex carbohydrates, a little more protein, and we do emphasize adding in some healthy fats for satiety. We've kind of presented this easy approach to building a low carb plate, encouraging patients to pick a protein source, add some non-starchy vegetables, add some fats, and add some complex carbohydrates. I think the other thing that I tend to use in my clinical practice, this is actually a strategy that I think is pretty easily integrated into short office visits when we're just trying to give patients some pragmatic, brief nutrition counseling. I think I tend to use this approach: pick a protein, add non-starchy vegetables, add some healthy fats, plus minus complex carbs. And then the thing that I like to add is giving permission to patients to skip a meal. We really want people to eat when hungry, stop when full. Obviously, for patients that are on mealtime insulin, that needs to be adjusted accordingly. But the idea that we need 3 meals a day and multiple snacks doesn't necessarily work for everybody. A very low carb plate looks fairly similar. Generally, we're reducing the intake or eliminating the complex carbohydrates and potentially replacing it with a slightly larger portion of something else on the plate. I think asking patients to, just take a slightly larger portion of non-starchy vegetables is a fairly easy way to replace the complex carb. It is definitely beyond the scope of today's talk to go into detail on the specifics of low carb eating. We know that MCT2D has so many lovely resources to support you and your patients in understanding kind of the ins and outs. I'm highlighting here MCT2D's new resource menu, which actually has QR codes that link to a variety of helpful resources, including snacks, recipes, a grocery list, how to build the low carb plate, and then Rena's lovely video series on intro to low carb eating. There are also a list of resources at the end of the slide, and I personally love this low carb cheat sheet because I think it makes low carb eating fairly simple. All right, so how do we personalize this? I think one key question is how many patients or how many carbs should my patient eat, or patient asking, well, where do I start? How many carbs should I eat? The reality is there's not really a specific answer. This is really more of an art than a science. And I think that's a theme that's going to come up through the second half of the presentation. We have to use best available evidence, sort of our clinical acumen, talk to patients about their preferences, and then sort of acknowledge that we might get it wrong the first time, and that as long as we communicate with our patient and we iterate on the plan and sort of take a data-driven approach to future modifications, for example, looking at blood sugar control, looking at what's happening with the weight, we can adjust the treatment as needed. So I would say a pragmatic place to start is wherever the patient is comfortable. We know in general that the lower the carb, the better the glycemic control and potentially more substantial the weight loss. However, patients may not be ready to jump into a very low carb eating pattern. And so they may choose 80 to 100 grams as an example, and then follow up with their blood sugar levels and body weight. Any questions so far or anything that I can answer? Keep going, but feel free to interrupt. So continuous glucose monitoring does offer a nice tool to guide nutrition counseling. I want to acknowledge that limited insurance coverage may be a barrier. I'm not going to discuss this in detail today. You can reference MCT2D's website for specific coverage information. I do also think it's worth noting that, many patients don't need to use a CGM for a long period of time to gain a lot of knowledge about their metabolism and how they respond to different foods. And so some patients without coverage may actually be willing to self-pay for a CGM for a finite period of time, particularly if the goal is explicitly to reduce their medications. The upfront cost of paying for the CGM may be offset by fewer medication co-payments down the road. So I think thinking about, 2 to 4 week bursts of CGM use for a patient that can self-pay might be a reasonable option. Organizations, including the ADA, are encouraging use of CGM to support healthy eating habits. I'm highlighting here a free continuing education course offered through the ADA. This is a series of I think 5 self-guided modules. They're pretty helpful. I think they reinforce some of the same things that we're talking about today. A key goal of continuous glucose monitoring is to optimize glycemic control, aiming for glucose variability less than 36%. And aiming for time in range, or defined as 70 to 180 milligrams per deciliter of at least 70%. So, it's, I think was I going to say anything else here? Okay, so I think that improving glycemic control can, of course, be achieved by adding more medications or engaging patients in specific lifestyle changes. And so I think our starting point depends, again, on patients' goals and preferences. Do they want to improve glycemic control, reduce medications, achieve weight loss? Each of these goals might have a different pathway. So, for example, I saw a patient in my primary care clinic last week who was on basal bolus insulin. His glycemic control is not where we want it to be. He is actually already using a CGM. And we talked about the option of modifying his lifestyle to avoid more insulin and potential for increased weight gain. And ultimately he said, you know what, I think he was in his late 60s, but whatever his age, I'm 68 years old. I really don't want to make specific changes. I want to enjoy my life. I'm okay taking a little bit more of insulin. And so for him, that's the patient-centered goal. Other patients might be willing to do anything to get off of insulin. And these are the patients where we really want to think about offering them the opportunity to restrict carbohydrate. A few disclaimers. I think, as we're thinking about carbohydrate restriction, particularly for patients that are on medications that can cause hypoglycemia, we really just need to remind ourselves that there are guidelines to guide medication adjustments. Certain medications like metformin and incretin mimetics, as well as DPP-4 inhibitors, will not cause hypoglycemia when used in conjunction with a very low carb diet. Unfortunately, these patients may be less likely to have insurance coverage for CGM. And so our patients who are using CGM may also beyond the medications most likely to potentiate hypoglycemia, including sulfonylureas, insulin, particularly bolus mealtime insulin. And so I will highlight in subsequent slides just sort of another reference that can maybe guide your management and reduction in meds. A key point that we emphasize throughout MCT2D and our talks on carb restriction is that if a patient is on an SGLT2 inhibitor, it should be stopped if they are consuming less than 50 grams of carbohydrate per day. This is to avoid the rare risk of euglycemic DKA, which really results from an insulin deficient state that allows for unopposed lipolysis or fat breakdown. This can result from pairing a very low carb diet with an SGLT2 inhibitor, because these are both interventions that reduce circulating insulin levels. There are other risk factors, right? It's not just very low carb diet. Other dietary changes, including very low calorie diet or MPO status, for example, a patient pre or post-op, as well as acute illness, can precipitate this condition. And the signs, can progress over time: abdominal pain, vomiting, weakness, fatigue, excessive thirst. Obviously, change in mental status would be a late and very concerning finding. There are guidelines to direct how we might reduce insulin levels and other medications that can promote hypoglycemia when initiating a low carb diet. Again, there's not, unfortunately, there's no algorithm for doing this. We are just using our clinical judgment. I think a couple of things can make this less scary. I think, for one, if the patient is using a CGM, you have access to a lot more data than someone who's just doing AccuCheck. And so you can give your patients guidance on how to self-adjust their own medications. I think the other thing that's useful is just recognizing that in the near term, and we'll see this when we circle back to Mr. L's case, it is okay to allow for slightly elevated blood sugar levels while patients are learning how to reduce carbohydrates. We don't want them to be persisting in the elevated range for months and months, but I think in the near term, hyperglycemia is less risky than hypoglycemia. And so being slightly more aggressive with reducing insulin and stopping sulfonylureas may ensure patient safety. Low blood pressure for patients on antihypertensive medications is also a potential risk. Encourage patients to self-monitor blood pressure, encourage excellent hydration, and then again, give patients permission to hold blood pressure medications and reach out to the clinic if there are signs and symptoms of hypertension. All right, so with that said, I kind of want to acknowledge again that providing intensive lifestyle counseling during brief primary care visits is challenging. I want to highlight sort of a few light touch, but potentially highly effective, less intensive nutrition counseling strategies that can be used, in just a few minutes during your primary care visits, particularly if a patient has, is using a CGM and you have access to that data. So, two common approaches to reducing carbs. These I took as screenshots from that ADA module I showed earlier on, and I think they're useful. One, first approach is reducing food portions. And I think this is probably should say reducing portions of high carb foods. We don't want patients necessarily reducing protein or other parts of their plate. And then the second option is just replacing foods that are high in carb with lower carb foods or less refined options. So let's look at a few examples here. This is an example of a patient who overall had fairly good glycemic control. He was enjoying, 15, 20 tater tots at dinner, and he recognized that if he just reduced the number of tater tots he was eating and didn't change anything else, his blood sugar remained in good control. An example of replacing high carb foods, this patient recognized that they had kung pao chicken with white rice one evening. Their blood sugar was elevated. They sort of understood conceptually that white rice is a refined grain and that this could be the culprit for the blood sugar elevation. Day 2, they had some leftover food and replaced the white rice with broccoli. Glycemic control is slightly better, but I think the patient appropriately says, why is my blood sugar still elevated? And I think this is where we can really help our patients look at nutrition labels and pay attention to hidden carbs. So in this particular case, the patient noted that they were adding some sauce, a stir fry sauce to the broccoli, and they estimated they were maybe getting 2 to 3 servings of the stir fry sauce in addition to what was already on the food. And when we looked at the label, we see that actually there's about 15 carbs additional to what they were consuming. So I think one key way to ensure that our patients are successful with this approach is to orient them to nutrition labels. Again, this can be a bit time consuming, and so MCT2D has resources to support that. Here is a really nice handout on understanding nutrition labels that is available at the website listed here. I guess the only other thing I will say here, in sort of referencing this example about hidden carbs and sauces, is that I always blame the food industry, right? I think that I don't want the patient to feel responsible for making the wrong choice. Obviously, this patient was trying to replace the grain with broccoli and felt that chicken and broccoli was a reasonable low-carb dinner, which it was. And people don't often think about hidden carbs in the food. And so just having this conversation that it's the food industry that puts sugar in many foods where you wouldn't expect it, and you just need to look at the label and do your homework on hidden carbs. The other thing that can support patient success is actually tracking carbs. There's a variety of resources to support carb tracking. I'm showing here a nice paper resource from MCT2D. There are also a variety of low carb tracking tools. Carb Manager, MyFitnessPal, Chronometer are some examples. And then I'm not personally familiar with Gluco, although I've heard that this is another nice free app for patients. Gluco is, a large company that often works with health systems to integrate glucose monitoring software in sort of a very expensive way, but the Gluco app is free for patients. It allows for carb tracking, and then I think there's also this option for voice entries, which is nice. Another strategy that can be integrated into office visits is just this idea of just changing breakfast. There's growing data to suggest that just changing breakfast from high carb to low carb can improve glycemic control over the course of the day. And I think this can be an important tool for patients. For one, breakfast foods like cereal, toast, oatmeal, smoothies are often really high in carbohydrate. The other thing is that a lot of patients have the most autonomy over breakfast because we're not typically sitting down and having a family breakfast and wanting to enjoy, what the rest of the family is consuming. So here's an example of a patient who had high blood sugar levels in the morning after consuming a fruit smoothie, and the patient was perplexed by this, noting that it has no added sugar and it has only 260 calories. When we Google it, which, if patients tell me a specific food item, I do tend to use Google to pull up the nutrition label so we can have a real-time conversation. 61 grams of carbs. That is a lot of carbs to start the day. And it's actually not that different than a can of Coke. So again, this is not about blaming the patient for making the wrong decision. It's blaming the food industry for mislabeling of foods and making us think that things are healthy that really are loaded with sugar. Lastly, I think that continuous glucose monitoring is a nice tool to sort of navigate nutrition controversy, meaning that we can find any, peer-reviewed scientific article or any sort of article in the lay press that labels certain foods or certain eating patterns as the best or the worst. There are no universally best or worst foods or eating patterns, and even things that are sort of labeled healthy might not agree with an individual patient's metabolism. One example is fruit. I have a lot of patients that are starting their day with a banana because it's quote unquote healthy, but if we look at the CGM data, it may be causing elevations, and we can encourage a little bit of self-experimentation. What happens if you have half a banana? What happens if you pair the banana with a protein and fat like peanut butter? Or what happens if you replace the banana with an egg, which is very low carb? Same is true for foods like oatmeal and yogurt. A lot of patients say, you know, I have to eat these foods because they're healthy. Again, if we can use a CGM to help patients understand whether or not these foods are causing blood sugar elevations for them personally, we can guide patients to kind of the right eating pattern, or an eating pattern that has the best metabolic fit for them. All right, so we will circle back to Mr. L, but I guess I will pause here and see if there's any other questions or any questions. So recall Mr. L is our patient with obesity and type 2 diabetes. He's on multiple medications, has adequate glycemic control, but is really frustrated by his condition. I think there's 3 things that I really want to emphasize as part of Mr. L's story. The first is that this is kind of an example of a very low carb eating pattern. I think within MCT2D, we tend to focus on lower carb eating patterns or low carb eating patterns. And we haven't focused as much on very low carb. Some patients are going to prefer and benefit from a very low carb, less than 50 total carbs per day eating pattern. The other thing that I want to kind of emphasize is that this is a nice example of team-based care. It might not be available in all of your settings, right? These resources may not be available in all of your clinical settings, but I think it's an opportunity to think about, you know, what team members are available and how can we work as primary care teams to better support our patients. And then I had a third reason for talking about his case, but I can't remember it. So I'll say it if it comes to me. But so I work as primary care physician and I practice obesity medicine at the Ann Arbor VA. One of the things that I've worked with my primary care team to do over the past several years is to develop what we call a low carb CGM program for patients with type 2 diabetes. This was initially designed for patients who were requiring basal bolus insulin. And we wanted to make sure patients were really willing to make intensive lifestyle changes. Patients needed to be willing and able to use a CGM, willing to learn to follow a carb-restricted eating pattern tailored to their CGM data, and they needed to be willing to meet regularly by phone or virtual conferencing with a pharmacist or a dietitian. This is a 6-month program, and we designed the program to be very intensive for 6 months, recognizing that if we invested resources in patients for a finite period of time and really worked to simplify medication regimens, get patients off of insulin, then these patients may require less support, and actually do require less support from us going forward. So this program is run by a clinical pharmacy specialist and a dietitian. The clinical pharmacy specialist has scheduled visits every 3 weeks for the duration of the program. They also periodically monitor CGM data and reach out to patients as needed to adjust medications. Initially, the dietitian sees the patient once a week for 4 weeks and then tailors the frequency of follow-up based on patients' needs. Patients are counseled to transition 1 meal a week from high carb to low carb. Patients are counseled to keep food logs and then use their CGM data to understand dietary drivers of hyperglycemia. We have MD oversight. So usually we have a once monthly team meeting where we discuss patients And then me as the MD involved in this program, I'm also available to the pharmacist and the dietitian if they want to reach out and ask any questions. We do check baseline labs. I think it would be reasonable, or we do check labs at baseline 3 and 6 months. I think we could, probably reduce lab frequency to just 0 and 6 months, but we're checking A1C lipids, CMP, and C-peptide. C-peptide, I think, is sort of the novel thing that we're checking, which is really to make sure that patients have endogenous insulin production before we think about reducing or stopping their exogenous insulin. I'll pause here and just say a couple of things. The first is that, this seems like a well-structured program, and now it is, but we didn't have a blueprint. We made this up. We had no clue what we were doing. We started with one patient, and we identified a patient that was highly motivated to make these changes. And we shared with the patient, we haven't done this before, right? We want to offer you something different. We haven't done this before. And we engage the patient as, a critical member of the care team. And so I think this can feel daunting, but with the right patient and the willingness to kind of learn together, I think it's very achievable. In our case, we limited it to just 10 patients. So even with this infrastructure, we felt like we could only safely handle 10 patients at a time. Depending on the resources you have available in your clinic, you might just start with one patient and see how it goes. We don't need to do this, and we unfortunately do not have sort of the clinical infrastructure to do this for all the patients that might benefit. So what did the program look like for Mr. L? Week 1, medication changes were started even before he initiated the diet. We stopped empagliflozin, as I mentioned earlier. We reduced his insulin from 180 units daily to 144 units daily, and his mealtime insulin was dropped from 22 to 10. When he met with the dietitian, he reported that he ate 2 home-cooked meals per day. They were high in carb. He liked things like sandwiches, pasta, hamburger helper, and rice. He was allergic to fish, doesn't like fruit, only likes cooked vegetables. He tends to avoid sugar-sweetened beverages, but unfortunately does have about half a gallon of vodka every 3 to 4 days. He says this is necessary for pain control. This is not something that he is willing to change at this point in time, and he's minimally physically active due to his chronic pain. The dietitian provides him with initial education on just carb counting. Now, in our program, we focus on net carbs, which are total carbohydrates minus fiber grams. The reason to do this is really to sort of allow for higher intake of high fiber foods like non-starchy vegetables. We encourage gradual transition, 1 meal a week, starting with breakfast, with a goal of 10 to 15 net carbs per meal. And then, of course, patients are counseled on signs and symptoms of hypoglycemia, how to manage. They're given permission to, hold their insulin all together, reach out to the team. And of course, we again counseled on reducing alcohol intake and staying hydrated with water. The reason for transitioning 1 meal per week from high carb to low carb is really intended to reduce the potential for side effects. Some patients do have symptoms of keto flu, which can be characterized by headache, fatigue, brain fog, or irritability. There are other potential side effects, including constipation, that we can work with patients to manage. And generally, the side effects associated with carb restriction are managed with liberalization of salt and water intake, sometimes a magnesium supplement, and certainly in this age of, GLP-1 centric approach to care, these side effects can be more tolerable than what we're seeing with semaglutide and other agents. So his CGM data, we did a lot of things at once. We reduced his meds. We introduced this new eating pattern. He had got good glycemic control previously, but we see time in range is only 38%. And, he has limited glucose variability because he's just running high. But this was permissible because, again, we're trying to avoid hypoglycemia while he adopts this eating pattern. And he gets the hang of it pretty quickly. Week 2, he says, I love pasta and rice, but I've learned I need to stay away from them. When he eats these foods, he does have elevations in his blood sugar levels. He also notes that he's browsed the stores and he sees all the the low carb and keto processed foods. And although he's been tempted to try some of the things like keto noodles and breads, he says these are just too expensive. A lot of the low carb packaged foods, particularly things like cereals and breads, can be very expensive. A low carb diet does not have to be expensive. And so here are some resources, including Low Carb on Any Budget. I love this PDF and use it with patients all the time, as well as MCT2D's Low Carb Dollar Store Roundup that can guide a budget-friendly approach to low carb eating. By week 3, he's totally gotten the hang of it. He has switched breakfast from high carb to low carb, and really all of his meals are fitting within his carb goal. He's having eggs and sausage. He continues to skip lunch, which was consistent with his baseline. He's having turkey with gravy and mashed cauliflower in place of potatoes and rice. And his snacks are almonds and cottage cheese in place of pretzels. He's no longer drinking milk. He does still drink vodka. And his CGM data reflects this change. He has low glycemic variability, and 98% of the time, he has blood sugars in range. And so I think this really highlights the potential for these changes to improve glycemic control rapidly. And he's really pleased that for the first time in years, he's losing weight. He lost 14 pounds or 4% of his body weight during this 3-week period. Now, of course, some of this is related, of course, to the water weight loss that we can see with carb restriction. But it's also potentiated by the fact that we're reducing his exogenous insulin, which has been previously inhibiting his ability to lose weight. So we make further medication changes. He doesn't need any mealtime insulin. His long-acting insulin is further reduced to just 100 units. And he sticks with the program. Really, like, his course was fairly simple. He didn't need month or weekly meetings with the dietitian for very long. And by the end of the 24 weeks, he had actually lost 46 pounds. He was off all of his medications with the exception of semaglutide. Now, maintaining any dietary change strategy is hard. Low carb is no exception. It is nice to build in resources to support maintenance over time. We do have a once monthly drop-in session for patients who have completed this low carb program. It's very well attended. Patients, group of veterans meeting virtually, just love to chat about how they're doing, and they really support each other. Frankie, who I think some of you know through the MCT2D conferences, as well as the video series, is a patient and peer support coach for this program, which he shared, which he talked about in his video. So how is Mr. L doing now? I saw him in clinic, I think 2, maybe 3 weeks ago. He said, honestly, things have been up and down. He did gain about 15 pounds over the winter. He was frustrated about poorly controlled pain, and he just sort of said, I gave up on my health. Thankfully, his PCP had stepped in. He was referred to pain clinic. He was started on an effective pain control regimen, and sort of shockingly, and I don't know what precipitated this, but he decided to stop drinking. He resumed his very low carb eating pattern, was able to start doing a little bit of walking. And here's the objective data that shows he's actually doing quite well, down 20% in his body weight over this period of time. His experience wasn't unique. I mean, this is what we're seeing with the patients that we're putting through this program. One patient said, I feel really good about what you've helped me do. Another said, my legs are stronger and I have more stamina. I am very happy. I'm very grateful. Another said, if I could have had this information as a young man, my whole life would have been different. Another noted, I'm down 5 inches in waistline, feelings of more energy, and I'm very happy with the results of this program. From a PCP perspective, PCPs have said this was very beneficial. Patients received a lot of individual attention. It was amazing because patients were taught how to modify their diet, learn how it affected their blood sugar, and then were often able to decrease their insulin requirements. As a primary care physician, it made our life so easy. I will also say, I guess what I didn't put in here is just the team perspective, but I actually met with the low carb team this morning, the pharmacist, the dietitian, and another physician. And I think what we consistently share among ourselves is that this is really hard work. It pushes us, but it is also the most rewarding part of our jobs. I don't think in primary care we often hear that we've changed someone's life or that we've done something that really transforms someone's health. A lot of times we're just controlling the numbers or adding medications, but this program really does have the opportunity to transform people's lives, and it's super, super hard and super rewarding. Mr. L was fortunate to receive his care at the VA, where we do have robust primary care teams consisting of physicians, nurses, pharmacists, dietitians, and social workers. Again, I realize these resources might not be available in your settings. I'm highlighting here another primary care-based intervention run by Dr. Richardson, who was the prior program director for MCT2D. And this was a lighter touch approach in a primary care setting at Michigan Medicine, with just infrequent visits with a dietitian, use of continuous glucose monitoring, and we still see improvements in A1C. So I think if you're thinking about ways to potentially integrate low carb counseling into your practices, I would refer you to this intervention. And then MCT2D really wants to support you in doing this. We're hoping to do some dietitian training, and we've developed a program called Low Carb Journey, which is a series of video modules really focused on very low carb eating. And we're hoping to make those available at some point in the future. And I'll just conclude by saying that weight loss can help patients with type 2 diabetes achieve glycemic control. There's no one size fits all approach. CGM can guide individually tailored dietary changes. And that, again, this is really hard, but super rewarding. Maybe just start with one patient and learn together. I'm happy to take any questions.
Thank you so much, Dr. Grasda. That was a great presentation, and I really like your advice of just like starting with one patient who's really motivated and kind of working through that journey together if it's new to how you practice. If anyone has any questions, we invite you to either put them in the chat and we'll read them aloud and answer them, or unmute yourself and ask as well.
There is one question in chat from Katie Gold. I don't know if you saw that. Just a question about one meal per week, meaning like breakfast every day, or like how does that one meal per week look?
Yes, exactly. Sorry, I should have clarified that. But yes, changing one meal per week. So starting with breakfast, week 1, just change breakfast. Week 2 would be lunch. Usually we do lunch and snacks. Week 3 would be dinner. That's one approach. Again, some patients are going to need more time to transition, and other patients are just going to say, I don't want to go gradually. I'm ready to kind of jump in all at once. They may be the ones with more side effects.
Okay, a few more questions in the chat. First one, thank you very much. Is there a way to get more availability for samples of CGM for patients with Blue Cross Blue Shield who are just on oral anti-diabetics since they changed their coverage policy? I personally can't speak to that. I don't know, Heidi, if you have any idea about like samples or like how they can increase the number of CGM samples available, or if any, or Lauren, if you want to jump into, or Dina, I don't know if you know, but.
Yeah, I think, oh, sorry, I can actually, Lauren, I see you too, so feel free to jump in.
Blue Cross Blue Shield, I think, is looking at this really carefully. So I'm going to say, hold tight. And once I hear back from them in a month or two, I will let everybody know. And Heidi, you might want to mention the patient empowerment toolkit.
Yeah, absolutely. So as a reminder for everybody on this call, with the changes in Blue Cross Blue Shield's coverage, we do have 4 patients with Blue Cross Blue Shield of Michigan, not out of state, and it has to be commercial, not Medicare Advantage, PPO plans. If they have lost their coverage, meaning they're not on insulin and had prior CGM coverage, or are coming to you and want to try out a CGM, if they have Blue Cross Blue Shield of Michigan commercial PPO, the patient empowerment tool gets them 6 free sensors. And so it can be used over the course of the year. They can't do this annually, but I think what I've been telling patients is, let's put a sensor on for 2 weeks. And then we're going to meet, we're going to go over the results, we're going to talk about what you can work on. And then maybe in 4 weeks or 8 weeks, we're going to put another sensor on. And so we stretch out the use of those 6 sensors. Meanwhile, patients constantly working on making these dietary changes.
Awesome. Thanks, Heidi, for bringing that up. Appreciate it. I do feel like the Patient Empowerment Toolkit program is really well set up, like specifically to support with the dietary intervention component. There was another question, Dr. Grazda. Someone said they'd missed the beginning of the talk. They were wondering why SGLT2 was stopped in the case example.
Yes, good question. So, and I should have maybe emphasized this a bit more specifically in the case example. But this patient, when given, presented with the options for restricting carbs, focusing on a very low carb approach versus a more, just a low carb approach with 50 to 130 grams per day, he opted to go for the very low carb approach. He felt like that would work well for him because he was planning to consume less than 50 grams of total carbohydrate per day. We stopped the SGLT2 inhibitor because there is that rare risk of euglycemic DKA if you pair an SGLT2 inhibitor with a very low carb diet.
There was a follow-up to the samples for CGM question, wanting to know if anyone knows of a way to get Dexcom instead of Libre 3, if there's a route to get those for patients. It doesn't have to be available to get receivers.
Unfortunately, I'm not familiar. I might rely on any of the other PharmDs that might use samples. At Michigan Medicine, we cannot use samples, so I don't have any direction there. I think Rachel just responded with an answer.
I don't know if that's the question, but I think that's what I was picking up on. The Libre 3 didn't have a receiver for a while.
The Libre 3 has a receiver. And that's why it didn't have one for a while, and it does now, which is why the Libre 3 is now covered on Medicare. Because it's the receiver portion that's considered DME by Medicare, and so the patient has to get that receiver.
So the question is the patient Medicaid
Stephanie, I'm trying to hear, but you're really broken. It could be my internet, perhaps.
No,
Jackie,
it was
are
cutting
you
out for me too?
I'm sorry, is that better?
Yes.
That is better.
Okay, sorry. So the patient is not Medicare age, so we can't get a receiver for him. And our Libre rep doesn't have the sensor availability for samples. I can only get contact of the Dexcom samples. So it kind of is like a little mix in between because the patient's iPhone is not up to date and it's too expensive to upgrade. So it was just a personal thing that our patient has. That Dexcom has the free receivers that we've been able to get. So I was just saying, like for future people, for how you guys do your little kit, the Libre doesn't work for him.
Got you.
Does that make sense? Sorry.
I think Stephanie, it does. Why don't you shoot me an email with a little bit more details, and okay. I'll try to digest it and see if I can come up with any solutions for you. But okay. That way you and I can email back and forth if I have questions to make sure I fully understand.
Thanks. And thanks, Rachel, for chiming in on that question. We really appreciate it. Any other questions at all? Well, thank you everyone so much for joining us today. And thank you very much, Dr. Grazda, for your presentation. The patient case was great and really appreciated the walkthrough of that.
Thank you.
All right. Have a great afternoon, everyone.